All right, welcome to the Explainer. Today, we are diving headfirst into one of the most intense, high-stakes fields in all of medicine, anesthesia for modern heart surgery. I mean, think about it. This is a world of incredible precision, where a specialist you never even see has to keep a patient's body running perfectly, even when their heart isn't running at all. I mean, that's the big question, right? How on earth do you run a human body when the heart is completely offline? Well, that is the central mission for a cardiac anesthesiologist. You can think of them as these unseen guardians, or maybe master conductors of the body's entire orchestra. They don't just put a patient to sleep. No. They are actively managing every single life-sustaining function while the heart is paused for repair, or sometimes even replaced entirely. So, here's what we're going to cover in this explainer. First, the minimally invasive revolution. Then, we'll look at how we support a failing heart. After that, the ultimate gift, transplantation. And finally, a really interesting topic, anesthesia for adult survivors. Let's dive in. All right, Section 1, the minimally invasive revolution. The subtitle here is Smaller Incisions, Bigger Challenges, and that really says it all. We're going to see how anesthesiologists make these incredible, futuristic surgeries possible, surgeries that used to be pure science fiction. So let's just compare the old way with the new way. For decades, open heart surgery meant one thing, a median sternotomy, literally cracking open the chest. And yeah, it works, but it's a huge physiological stress on the body, and the recovery is long and tough. But now, we have these hybrid and robotic procedures. We're talking tiny little incisions or ports. Patients get back to their lives so much faster. But, and this is a big but, this whole new approach demands completely new strategies from the anesthesia team. And this all goes down in what's called a hybrid operating room. It's this wild combination of a classic surgical suite and a high-tech imaging lab with things like fluoroscopy. So for procedures like a TAVI, that's a valve replacement, or a MitraClip repair, the anesthesiologist using this amazing tool called a TEE, or transesophageal echo. It's basically a live ultrasound probe that goes down the esophagus and gives them a perfect view of the heart. They're guiding the whole thing from the inside. And for robotic surgeries, get this. They often have to perform one lung ventilation. They literally shut down one lung to create enough space for the robot's arms to work. It's incredible. So let's be clear, this is not a passive role. The anesthesiologist is right in the thick of it. Let's take a MitraClip procedure. First, sure, they induce general anesthesia and insert that TEE probe. But then, they're using that probe to guide the surgeon as they make a puncture between the heart's chambers. They have to carefully manage the anticoagulation, the blood thinners, to prevent clots. Then, they guide the deployment of the clip right onto the mitral valve leaflets. They're seeing it all in real time. And once the clip is placed, they're the ones who assess if the repair worked before the patient is weaned from support. They are, quite literally, the eyes of the surgical team. Okay, moving on to Section 2. Supporting the failing heart. The subtitle is When the Engine Weakens. And that really sets the stage. We're now moving into the absolute highest stake scenarios, managing patients whose own heart is in the final stages of failure. Every single move here is critical. So, what exactly is heart failure? It's not like a heart attack, which is a sudden event. It's a complex, progressive syndrome. Basically, the heart muscle gets weaker and can't pump enough blood to meet the body's needs. For a while, the body tries to compensate. It works harder, it adapts. But eventually, those adaptations just can't keep up anymore. They fail. And you get to a point where the heart simply can't do its job, and medications alone aren't going to cut it. To understand this decline, doctors use something called the intermax profiles. You can really think of it as a ladder of declining health. At the bottom, in profiles 5 to 7, you've got patients who are intolerant to exertion. But as you climb up, things get more serious. Profile 3 means you're stable, but only because you're dependent on IV heart medications, called inotropes. Then you hit Profile 1, critical cardiogenic shock. The grim nickname for this is crash and burn. This scale is absolutely vital because it helps everyone decide when it's time to pull the trigger on a major intervention, hopefully before the other organs start to shut down. So, when medical therapy just isn't enough, we call in the cavalry. mechanical circulatory support, or MCS. The most common form of this is a VAD, a ventricular assist device. It's an incredible piece of technology, a surgically implanted pump that literally takes over the work of the failing heart. It can serve as a bridge to transplant, which means it keeps a patient alive and stable until a donor heart becomes available. Or for patients who aren't transplant candidates, it can be the final treatment, what we call destination therapy. And just look at the impact of this tech. It's staggering. We're talking about an approximate 80% one-year survival rate for patients with modern VADs. For people whose prognosis was once measured in weeks or months, this is a game changer. It's an incredible lifeline. And you can bet that managing the anesthesia to get these devices implanted safely is a complex and demanding subspecialty all on its own. And that brings us to Section 3, the ultimate gift, transplantation. This is really the pinnacle of cardiac surgery. But it comes with a truly unique, mind-bending challenge for the anesthesiologist. How do you manage a brand new heart that's completely disconnected from the body's own nervous system? This is the core concept you have to grasp, the denervated heart. When a surgeon puts a donor heart into a recipient, all the nerve connections are cut, all of them. So this new heart is basically an island, operating independently. It can't get any direct signals from the brain to speed up or slow down. It just beats at its own natural intrinsic rhythm, usually somewhere around 90 to 110 beats per minute. To respond to stress, like exercise or fear, it has to wait for hormones like adrenaline to circulate through the blood and reach it. And this table shows you exactly why that whole denervated concept is so critical. A drug like atropine, which we'd normally use to speed up a slow heart, it works by blocking nerve signals. But in a transplanted heart, there are no nerve signals to block, so it does absolutely nothing, zero effect. This means the anesthesiologist has to throw out the standard playbook and use a totally different set of tools. They have to rely on direct-acting drugs, like epinephrine, that stimulate the heart muscle directly. Okay, for our final section, we're going to look at something really fascinating, a field that, in a way, is a product of its own success. Section 4. Anesthesia for adult survivors. We're talking about providing a lifetime of specialized care for people who survived complex heart surgeries when they were just babies or children. So this is the question. What happens when the miracle babies of heart surgery grow up? You know, decades ago, pioneering surgeons started performing these incredible repairs on infants born with really complex congenital heart problems. And it worked. But now, those kids are adults. And they're coming back to the hospital, sometimes for another heart surgery, but often for something totally unrelated, like having their appendix out. And they arrive with a physiology and internal plumbing that is utterly unique to them. And managing anesthesia for these patients, well, it's like solving a completely custom-built puzzle every single time. Their internal anatomy has been literally replumbed with things called baffles, conduits, and patches from their childhood surgeries. In some cases, their right ventricle, which is naturally designed for the low-pressure job of pumping blood to the lungs, has been surgically rerouted to do the high-pressure job of pumping blood to the entire body. That's a huge strain. Add in things like chronic low oxygen levels, high pressure in the lung arteries, and a higher risk of arrhythmias from old scar tissue, and you have a massive set of challenges. So here's why all this really matters. For this growing population of adult survivors, anesthesia is never routine. It doesn't matter if they're in for a major heart operation or something simple. The anesthesiologist has to have a deep, profound understanding of that person's specific surgical history and unique physiology to keep them safe. And that's exactly why having specialized adult congenital heart disease centers is so incredibly important for helping these patients live long, full lives. So when you think about it, from guiding tiny clips through blood vessels to managing a heart with no nerves at all, the art of cardiac anesthesia is in a state of constant, rapid evolution. It really is this silent, crucial partnership between incredible human expertise and amazing technology. So as our surgical and tech abilities get more and more sophisticated, you have to ask, what new frontiers will these unseen guardians of the heartbeat conquer next?